we tend to assume, that modern medical science is this perfectly objective map of reality. Like you go to the hospital with a pain, they run a scan, pinpoint the exact organ, and the diagnosis just feels as concrete as engineering.
Right. It feels very definitive today.
Yeah. But when you actually dive into the historical sources mapping the human body, especially our internal organs, well, that illusion of precision just completely shattered.
Well, absolutely. The anatomical landscape is honestly a mess, historically speaking. I mean, it is incredibly murky.
Yeah, totally.
We are dealing with centuries of guesswork, mistranslations, and just constantly shifting paradigms long before anyone could confidently point to a specific organ and, actually define its job.
Welcome to today's deep dive, where our mission is to cut through all that historical fog. We've got a really fascinating stack of sources today encompassing medical history, etymology, and even modern clinical pharmacology.
And it is all centered around decoding one foundational medical root, which is gastro.
Right, which you probably know relates to the stomach. But mastering this single root, it offers a shortcut for you to understand both your own everyday health and, honestly, the explosive debates surrounding today's headline-making weight loss drugs.
Yeah, it really serves as a skeletal framework because once you grasp how the medical establishment defined, misunderstood, and eventually mapped the gastro system, you gain this amazing ability to decode complex medical charts.
And just understand the actual mechanics of digestion,
That's
right?
exactly.
Okay, let's unpack this, because we have to start with the sheer confusion of the ancient world. Looking at our sources to understand the stomach, we first have to realize that ancient physicians didn't even conceptualize the abdomen the way we do today.
No, not at all. They weren't looking at discrete, clearly defined organs like we see in a modern textbook.
Right.
Tracing the root gastra back to ancient Greek reveals a fundamentally different view of human anatomy. I mean, the original word gaster did not refer to the highly specific, J-shaped internal pouch that we call the stomach today.
Wait, so if they weren't talking about the stomach as an organ, what were they actually describing?
They were describing a visible territory. Gastr meant the general belly, the paunch, or really just the bulging part of the human trunk.
Wow, okay.
Yeah, it's a topographical term, not an anatomical one. It was actually so generalized that early writers frequently associated it with pregnancy.
Oh, interesting.
Right. A woman with a large, growing belly was described using variations of gast.
That implies they were basically practicing medicine from the outside in. Like, without standardized human dissections, they couldn't draw borders around internal structures.
Exactly.
So they just pointed at the whole midsection and treated it as this single, vague zone?
Well, the underlying logic of their medicine basically demanded that approach. Influential physicians like Galen in the 2nd century, they operated under humoral theory.
The four humors, right?
Yeah. Right. They believed human health was dictated by the balance of systemic fluids, and that this was all driven by innate body heat. So when they conceptualized digestion, they viewed the gaster as a literal internal furnace.
A furnace, like literal fire.
Well, heat. They used the Greek term pepsis, meaning concoction or cooking. The prevailing theory was that the heat of the surrounding organs literally cooked the food sitting in the belly.
See, that fundamentally changes how you would treat a patient, because if the stomach is a furnace, indigestion isn't like a chemical imbalance.
Yeah.
It's a temperature problem. The medical interventions would be entirely focused on heating up or cooling down the patient rather than, addressing the local tissue.
Which is exactly why it took a monumental timeline of anatomical bookkeeping to correct the record on this.
Yeah, I bet.
Moving from a generalized belly furnace to a specific discrete organ, it required centuries of empirical observation. The process started with Hellenistic dissections in Alexandria, but it didn't really gain true scientific traction until Andreas Vesalius published his highly detailed anatomical drawings in 1543.
Based on actual human dissections.
Oh, yes.
Exactly. And the sources point out that even then, it wasn't until Giovanni Battista Morgagni in 1761 that the clinical thinking actually shifted.
Right.
He performed these exhaustive autopsies to prove that diseases don't arise from a general systemic imbalance of humors. They originate in specific, localized tissue.
And Morgani's work was the watershed moment, because once the medical community accepted that an ulcer or a tumor is a localized pathology, well, they had to carve up the vague territory of the belly into distinct neighborhoods.
They needed a better map.
Right. So sibling roots were assigned to new territories, like entero claimed the intestines, and by convention, the scientific community narrowed that ancient word gastro down to label only the specific organ where gastric juices are produced.
Okay, but here is the linguistic contradiction that completely threw me while I was reading these sources. If the medical community narrowed gastro to mean the stomach,
Yeah,
the actual English word stomach doesn't share that origin.
it doesn't.
The medical root and the everyday word come from two entirely different ancient concepts.
The etymological drift here is so fascinating. The English word stomach actually derives from the Greek word stomachos.
Okay.
And originally, stomachos had absolutely nothing to do with the belly. It was derived from stoma, meaning mouth or opening. In ancient texts, stomachos referred specifically to the throat, the gullet, or the esophagus.
Wait, really? The English word for our primary digestive organ originally just meant the throat.
Yep. Over several centuries of vernacular English, the meaning of stomach slowly drifted southward down the digestive tract, and it eventually settled on the organ just below the esophagus.
That is wild.
And simultaneously, the medical community took the separate Greek root for the bulging belly gaster and shrank its definition inward to apply to that exact same organ.
So we ended up with two completely unrelated ancient words, one meaning throat and one meaning paunch, basically crashing into the same J-shaped pouch by pure historical accident.
Exactly. And because of that ancient vagueness, there are a few etymological false friends that you really need to be aware of.
Oh, right, the false friends?
Yeah, because when you see gastro in a scientific term, your modern brain immediately jumps to digestion. But since the ancient Greeks used it to describe anything that bulged like a belly, it shows up in completely unrelated fields.
The gastrocnemius is the classic example from the sources. It is the large, powerful muscle at the back of the human calf.
Right.
It has absolutely zero functional connection to digestion, but early anatomists named it the gastrocnemius simply because the muscle belly bulges out prominently.
Basically a little leg belly.
A little leg belly. I love that.
Embryology gives us another one too, which is gastrulation. This is the phase where an early embryo folds inward to create a cup or pouch shape known as a gastrula.
Ah, so again, nothing to do with food.
Right. The term relies entirely on the architectural concept of a pouch, drawing on the ancient Greek visualization of the gaster rather than anything clinical. Oh, and you also have to watch out for words like gastric and gestation. They sound similar, but gestation is Latin and totally unrelated.
Good to know.
Yeah.
So knowing all that history, we have to look at how the medical community finally figured out the mechanics of this organ. I mean, if they're working with a legacy of humoral theory and confused terminology, moving from the concept of a furnace to a nuanced understanding of biochemistry required a massive leap.
A huge leap. And that leap required direct empirical observation of the organ in action.
Literally looking inside a living one.
Yes. And the most critical breakthrough didn't happen in some pristine European university. It happened on the American frontier in 1822, involving a U.S. Army surgeon named Dr. William Beaumont and a young fur trader named Alexis St. Martin.
This story is incredible. St. Martin suffered a catastrophic injury on Mackinac Island in Michigan. He was accidentally shot in the abdomen at incredibly close range with a musket.
Which, a wound like that in the 1820s was almost universally a death sentence.
Oh, for sure. But the survival of the patient was remarkable. The anatomical aftermath, though, is what changed medical history, because the wound healed atypically, leaving a permanent fistulous opening.
A literal unhealed tunnel.
Yeah, directly from the outside of St. Martin's abdomen into his stomach, protected only by a small flap of tissue.
It's hard to even imagine. And, modern protocols would obviously demand immediate surgical closure. But Beaumont, well, he saw a bizarre and somewhat ethically fraught opportunity.
To put it mildly.
Right. Instead of attempting to permanently close the fistula, he retained St. Martin and spent the next decade conducting over 200 documented physiological experiments right through that opening.
The methodology was incredibly crude, but undeniably effective. Like, Beaumont would tie various pieces of food, meat, bread, cabbage to a silk-string, lower them directly through the fistula into the living stomach, and extract them hours later to observe the rate of dissolution.
And crucially, he also extracted the raw gastric juice itself. He took it outside the body to prove that it could dissolve food in a vial at room temperature.
Which fundamentally dismantles the furnace theory. If the juice can digest food in a glass vial sitting on a table, innate body heat isn't the primary driver. It is a chemical process.
Exactly.
But here's where it gets really interesting. The detail in the sources that really caught my attention wasn't the chemical extraction. It was Beaumont's visual observations of the stomach lining itself.
Right. He noted that the physical appearance of the gastric mucosa changed dramatically depending on St. Martin's emotional state.
Wow.
If the patient was angry, irritable, or stressed, the mucosal lining would visibly redden, pale, or completely alter its secretions.
That is a direct visual confirmation of the gut-brain connection in 1822. Long before we had neurogastroenterology, Beaumont was physically watching human emotions dictate the physiological behavior of an internal organ.
It is a profound realization, but emphasizing the stomach's dramatic chemical and emotional reactivity often leads to a really persistent modern misconception.
Oh.
Because we feel our stomachs churn when we're anxious, and because gastric juice is so potent, people tend to assume the stomach is the master synthesizer of the digestive system, like the place where food is fully broken down and absorbed.
Yeah, the analogy most people use is a mechanical blender. You put the food in, the stomach purees it, and the body absorbs the nutrients directly from there.
But the mechanical reality is quite different. The stomach is really primarily a holding tank and a sterilization chamber. The highly concentrated hydrochloric acid serves to kill ingested bacteria and pathogens.
Right.
And a specific enzyme, pepsin, begins cleaving apart complex protein chains. But the stomach actually absorbs almost zero nutrients, aside from water and certain compounds like alcohol.
So its primary job is essentially aggressive prep work.
Very aggressive prep work. It aggressively churns the food, sterilizes it, and reduces it to a highly acidic paste called chyme.
Okay, so if the stomach isn't doing the absorbing, who is?
The actual heavy lifting of chemical digestion, breaking down carbohydrates and fats, and absorbing the vast majority of nutrients into the bloodstream. That happens downstream in the small intestine, heavily assisted by enzymes from the pancreas and bile from the liver.
Okay, so understanding the stomach as an interconnected prep cook rather than a standalone blender, that actually explains the logic of the medical terminology.
How so?
Well, the root gastro rarely operates in isolation. It basically functions as an anatomical anchor, connecting to a whole network of surrounding organs and procedural suffixes.
That's a great way to look at it. Medical terminology acts like an architectural blueprint, or like
Yes.
Lego bricks. Once you identify the root organ, you combine it with prefixes, sibling roots, and suffixes to precisely map the pathology or the procedure. And the connecting vowel, usually an O, just smooths the pronunciation between the modular blocks.
Okay, so looking at the surrounding abdominal network, if we connect gastro with entero, which is the root for the intestines, we build gastroenterology, the study of the stomach and the intestines as a continuous system.
Exactly. And if you add the suffix itis, indicating inflammation, you have gastroenteritis. Clinically, this is inflammation of both the gastric and intestinal linings,
Which people usually just call the stomach flu.
which is a terrible misnomer. I always have to clarify this. The influenza virus causes respiratory illness. Gastroenteritis is almost entirely caused by completely different viral or bacterial agents attacking the digestive tract.
Right, not the flu at all. And the blueprint extends upward and laterally as well. You've got esophago for the esophagus, creating terms like gastroesophageal reflux disease,
Also known as GERD.
right, GERD, where the acidic chyme we just discussed violently splashes back up through the sphincter. Then you have hepatomapping the liver and pancreatomapping the pancreas.
And what's fascinating here is the most mechanically interesting neighbor, the pylorus, which uses the root pylora.
The gatekeeper.
Precisely. The pylorus is the heavy muscular valve at the inferior end of the stomach. Its sole job is to control the extremely slow, metered release of that acidic chyme into the delicate small intestine.
So it's basically the bouncer.
Exactly. So if a patient presents with pyloric stenosis, which is a condition frequently seen in infants, the architectural term tells you exactly what is failing. Stenosis means an abnormal narrowing, so the gatekeeper muscle has thickened, completely blocking the prep cook from passing the food downstream.
Oh, that makes so much sense when you break it down. And the procedural suffix is attached the exact same way.
Yeah.
Like an encounterectomy is a surgical removal, giving us a gastrectomy. An encounteroscopy is a visual examination, so a gastroscopy involves threading a camera down to inspect the lining.
And a castrostomy creates a new surgical opening. So a gastrostomy is where a feeding tube is placed directly through the abdominal wall, entirely bypassing the throat. You also have alga for pain, megaly for enlargement, and terms like epigastric to describe a regional location.
It's amazing. By understanding the structural logic of these terms, you aren't just memorizing a vocabulary list. You are tracing the physical and mechanical relationships inside the human body.
You really are.
But, and this is a big but, the sources present a chilling counter-narrative here. We can have a perfectly logical vocabulary, we can map the anatomy flawlessly, and the entire medical establishment can still get the actual pathology of a disease dangerously wrong.
Oh, yeah. The story of the ulcer debate is an absolute masterclass in clinical hubris.
It really is. I mean, imagine the frustration.
It remains one of the most sobering cautionary tales in modern medical science. Because for the vast majority of the 20th century, the absolute unquestioned dogma was that peptic ulcers, which are painful sores in the lining of the stomach and upper intestine, were a lifestyle disease.
Right. The prevailing narrative was completely psychological. If you were an overworked executive enduring high stress and eating a spicy diet, you were triggering your stomach to overproduce acid, effectively burning a hole in your own organ.
And the standard of care was just prescribing bland diets, advising rest, and administering antacids.
Which didn't cure anything.
No. But the clinical consensus was rock solid until the early 1980s, when two Australian researchers, pathologist Robin Warren and physician Barry Marshall, challenged the foundational premise of gastric biology.
So what did they find?
Well, Warren observed spiral-shaped bacteria thriving in the biopsy tissues of ulcer patients.
Which, based on everything we just discussed about the stomach's mechanical function, should be biologically impossible.
Right.
The primary purpose of the stomach's hydrochloric acid is sterilization. The pH level of a human stomach usually rests between 1.5 and 3.5. That is comparable to battery acid. The establishment believed a sterile stomach was a law of nature.
And so, when Warren and Marshall presented their findings, they were completely dismissed. The broader medical community just assumed the tissue samples were contaminated during the biopsy process.
Of course.
But the two researchers managed to successfully culture this specific organism, later named Helicobacter pylori, directly from the highly acidic stomachs of multiple ulcer patients.
But wait, how does an organism survive an environment designed to dissolve living tissue?
H. pylori utilizes a brilliant evolutionary defense mechanism. It burrows deep into the thick mucosal lining of the stomach, effectively hiding from the raw acid.
Ah, sneaky.
And more importantly, it secretes an enzyme called urease, which reacts with urea in the stomach to create a localized bubble of ammonia around the bacteria. This actually neutralizes the acid in its immediate vicinity.
A little anti-acid force field.
Basically, yeah.
But even with that mechanism explained, the establishment vehemently rejected their hypothesis that a bacteria caused ulcers. And Marshall and Warren faced a massive ethical hurdle. They couldn't intentionally infect a healthy human test subject with a theoretical pathogen just to prove a point.
Right, IRB boards frown on that. So Barry Marshall's solution to that ethical blockade was to remove the external test subject entirely.
This is the craziest part.
Driven by just the sheer frustration of observing empirical truth while facing universal rejection, Marshall took a beaker containing a cultured broth of H. pylori and intentionally drank it.
He weaponized his own gastro system to break the dogma.
He did. Within days, Marshall developed severe acute gastritis. He documented the onset of nausea, vomiting, and halitosis. He then underwent endoscopic biopsies to definitively prove that the bacteria had colonized his previously healthy stomach, causing the severe inflammation.
And he won.
He did. Having proved the pathogenesis, he successfully eradicated the infection and cured his own gastritis using standard antibiotics.
I mean, just imagine the sheer vindication. Knowing you're right while the entire world tells you you're wrong, and then proving it like that. That self-experiment shattered a century of medical assumption.
It really did.
By proving that peptic ulcers were primarily an infectious disease rather than a psychiatric failing, Marshall and Warren revolutionized gastroenterology, ultimately sharing the 2005 Nobel Prize in Physiology or Medicine.
And their discovery fundamentally altered our physiological understanding of the organ. Plus, it coincided with another major paradigm shift regarding how the stomach communicates with the rest of the body.
Right, because for centuries, the stomach was viewed as a passive mechanical sac that merely reacted to the presence of food.
But the discovery of gastrin added an entirely new layer of complexity. In 1905, a physiologist named John Sidney Edkins theorized that the stomach didn't just secrete acid automatically.
What was his theory?
He hypothesized the existence of a chemical messenger gastrin that actively signaled the stomach to begin production.
And the sources say it took nearly 60 years of technological advancement before researchers could finally isolate gastrin in 1964.
Yeah, but they proved that specialized G cells in the stomach lining detect the arrival of proteins. They respond by releasing the gastrin hormone into the bloodstream, which then stimulates other cells to pump out the hydrochloric acid.
That elevates the stomach from a simple mechanical churner to an active endocrine organ. It is constantly monitoring its environment and dispatching hormonal commands.
And that endocrine capability is exactly why the stomach has become the absolute epicenter of the most contentious medical debates of the mid-2020s. We are currently witnessing an unprecedented battle over how to manipulate the gastro system to treat systemic metabolic disease.
Right. And the first front of this battle is surgical. We are physically altering the architectural blueprint through bariatric surgery.
Procedures like the sleeve gastrectomy radically modify the anatomy. Surgeons permanently remove 75 to 80% of the stomach, reducing it to a narrow tube.
That's a huge reduction.
It is. Alternatively, the Roux-en-Y gastric bypass physically divides the stomach into a small upper pouch and surgically reroutes the small intestine to connect directly to it, intentionally bypassing the majority of the stomach's anatomical real estate.
Now, these architectural alterations are undeniably effective for forcing weight loss and even sending severe type 2 diabetes into remission.
Very effective.
But there's a big debate around long-term nutritional risk.
Right.
Like, why accept the permanent, lifelong risks of nutritional malabsorption if we can just manipulate the stomach's endocrine system pharmacologically?
This raises an important question, and it's the exact question driving the explosion of GLP-1 receptor agonists drugs like Ozempic and Wegovy.
Right.
These medications mimic a naturally occurring hormone to regulate blood sugar, but their profound impact on weight loss relies heavily on altering the mechanical operation of the stomach itself.
But how exactly does a hormone injection basically paralyze a digestive organ?
Well, GLP-1 drugs bind to specific receptors in the gastrointestinal tract in the brain, and when these receptors are stimulated, they heavily inhibit gastric motility.
They slow down the churning.
Dramatically. The strong, rhythmic, muscular contractions that the stomach uses to churn food and pump chyme through the pyloric valve are slowed down.
So the stomach physically holds onto the food longer, sending a sustained signal of fullness to the brain, which extinguishes the appetite. But manipulating that mechanism has triggered a massive clinical and legal debate regarding a specific condition, gastroparesis.
Let's analyze that term using our blueprint. Gastro is the stomach, and paresis indicates partial paralysis. So gastroparesis is a severe delay in gastric emptying.
And our sources note that the medical community is currently really fractured over this. Like, is it a feature or a bug?
Yeah.
If the explicit intended mechanism of the drug is to slow down the stomach, is mild gastroparesis just proof that the drug is doing its job?
Or is the profound paralysis seen in a subset of patients an underappreciated, potentially catastrophic risk?
Right.
And honestly, the clinical data is still evolving in real time on this. Proponents argue that delayed emptying is the necessary therapeutic mechanism for satiety.
But critics point to those alarming case reports.
Exactly, the ones where the muscular paralysis is so severe that patients suffer intractable vomiting. And more concerningly, the paralysis does not immediately resolve when the medication is discontinued. We are actively discovering the long-term consequences of chemically overriding the stomach's innate rhythm.
Wow. We have mapped an incredible amount of territory today, moving from ancient philosophy to cutting-edge pharmacology.
We covered a lot of ground.
So what does this all mean? Let's distill this deep dive into 5 core takeaways for you. Number 1, the ancient Greek origin. The root gastro originates from Gastr, which described a bulging belly rather than an internal organ, explaining its presence in terms like the gastrocnemius muscle.
Right.
Number 2, the etymological accident. The English word stomach evolved from a Greek term for the throat, resulting in 2 unrelated ancient words colliding on the same organ.
Number 3, Dr. Beaumont's empirical window. The 1822 experiments on Alexis St. Martin's fistula-approved digestion is a chemical process driven by gastric juice, not innate body heat.
Number 4, the mechanical reality. The stomach acts as a prep cook, churning and acid-sterilizing food, while the small intestine handles the actual chemical absorption.
And number 5, the ulcer revolution. Barry Marshall's incredible self-experiment dismantled a century of dogma, proving that H. pylori bacteria surviving in extreme acid cause ulcers, not stress.
It's amazing. Every one of those historical milestones required a willingness to look past the established consensus.
They really did. And if we want to synthesize everything we've discussed today into a final, provocative thought, let's connect Dr. Beaumont in 1822 directly to the GLP-1 pharmacology of today.
Oh, I like this. The physical window versus the chemical window.
Exactly. Think about it. When Beaumont looked through that fistulous opening, he saw the stomach lining physically alter its color and secretion based on the patient's emotional state.
Anger and stress manifested physically in the gut.
Right. But today, we are deploying GLP-1 drugs that artificially paralyze the stomach's muscular contractions, and by doing so, we are profoundly altering neurological cravings, emotional desires, and psychological satiety in the brain.
Wow. So the communication isn't just top-down, it's a closed loop.
It is a continuous bidirectional feedback loop. If our emotional state can physically inflame the stomach and chemically altering the stomach can rewrite the brain's baseline desires, we really have to question the utility of treating them as two isolated systems.
That's a profound thought.
The architectural blueprint of the future might require us to stop viewing the brain and the gastric system as separate entities and start treating them as two halves of a single, deeply intertwined conversation. The next time you experience a gut feeling, you may want to interpret it literally.
A deeply intertwined conversation that completely redefines how we think about our own biology. Well, thank you for joining us on this deep dive. Keep questioning the consensus, keep decoding the world around you, and we will see you next time.